The Senior Rehab Podcast is sponsored by Health IQ. Health IQ is a special rate life insurance company for health-conscious people like you and me. If you're in the market for life insurance to have peace of mind and to protect your family, I'd highly recommend checking out this company. They are the only life insurance company to use data to leverage lower life insurance rates for active individuals. So the result is that 56% of Health IQ customers save between 4 to 33% on their life insurance premiums, which can definitely add up to big savings over time. To find out more information, just go to healthiq.com/SRP to support the show and to get your free quote. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hey there, Senior Rehab Podcast listeners.
I'm Erin Carey.
And I'm Towle Spaceman.
And we are here talking about an article called Health Outcomes Associated with Polypharmacy in Community Dwelling Older Adults, a Systematic Review. So we're stepping away from our frailty series, and now we're talking about something that Tully and I have really wanted to talk about for a while, which is polypharmacy in community dwelling older adults.
Yeah. On average, like if you had to take a guess of the average of how many drugs are your patients on, like on average, like, you know.
I work in a hospital.
Yeah, so how many? A lot.
Probably like 10, 20. Like some ridiculous amount, truly.
And it's not only things that were given to them in the hospital, it's, you know, most of them they came with, and maybe they added 3 or 2 more in the hospital.
12, 18, it's fine.
It's,
So it's something I've wanted to learn more about.
Yeah, I remember like 5 years ago, I had a patient that we were talking. I like to talk with my patients about aging. It's acknowledging the elephant in the room. And he said, you know, when I realized I'm old, when I realized that I have a schedule for when to take drugs and how many pills I take a day.
Yeah. That's, yep. Womp.
Let's make it fun now.
Whee! So this article was published in the Journal of the American Geriatric Society in 2014. So it's a little older than what I like to do, but I thought it was a really interesting one. The first author is actually Freed, but it's a different Freed. So this one is Terry Freed, who is a professor of medicine at Yale University, versus Linda Freed, who's the dean of Columbia School of Public Health. And she's the one, the public health Columbia person. She's the one who came up with the criteria that we call the Freed criteria. This article starts out with the introduction, and they bring up the prevalence of multimorbidity using data from 100% of Medicare claims from 2008. And just so you know, 83.5% of Medicare's beneficiaries are over the age of 65. So this is from that pool of data. So 67% of these people in 2008 had 2 or more chronic conditions. And then in the cohort of 85 years and older, 81.5% of them had 2 or more chronic conditions. So when you have multimorbidity in this population, you're probably going to be taking multiple medications. So in a 2003 survey of Medicare patients, 90% of them were taking at least 1 prescription, and 46% of them were taking 5 or more prescriptions. Polypharmacy is a fact of life for a lot of our patients. So that's another reason why we really wanted to dive into this. Polypharmacy, there are 2 prevalent definitions.
Of course, why would there be only one?
Only one.
Why would there be?
Yeah, as I was reading this, I was like, it's like frailty all over again.
It's my nightmare. Yeah. There's no definition.
It's just define things. The first prevalent definition of polypharmacy is the use of multiple medications, but there's no consensus on what that number is. The second is the use of inappropriate medications regardless of the number. So then the risks of polypharmacy exponentially increase the number of combinations. They can cause adverse reactions, and then drug-to-drug interactions are really common as well. This next part that they talked about in this article kind of scared me. It said that data about medications and their risks and benefits comes from randomized controlled trials, which by design exclude patients with multimorbidity. So we have no idea what's going on. It's just crazy. It blows my mind. Do you have anything you want to say to that? Was it terrifying?
That we never really know?
We have no idea.
We never really know.
The list of side effects and risks that you get with your little packet of medication, that's just from randomized controlled trials or from, what's it called? When they do monitoring after a drug is released. So yeah, that was terrifying to me. These authors wanted to look at health outcomes associated with polypharmacy, which was the goal of their review. And their specific question was, among community living persons aged 65 and older receiving outpatient care, what are the clinical outcomes associated with polypharmacy related to medications taken for chronic conditions? Which is a nice, succinct question. So their methods, they only looked at Medline, and they looked at articles from 1946 to May 2014, and it's specifically Ovid Medline, which will be important in a second. They looked at articles that examined 4 or more medications and or drug burden, those terms, in persons 65 years and older. And they stated that their search methodology was not limited by study design or language of publication, and I have no idea how that's possible. Language.
Maybe they have, like, I can understand having up to 5 languages, like, in your team of researchers.
Right.
I can understand how, we have someone who speak Cantonese, we have someone who speak German, but I cannot believe there was no limitation, unless they are like thesaurus or whatever.
They could be. They maybe had Google Translate. They did.
I do not want my research to be based on Google Translate.
That's probably smart. Okay. So they put their search strategy in an appendix, and it's not very descriptive. It's this table, and it has these particular suffixes like .tw and .mo, which I learned. I really fell down the rabbit hole with this one. So they're all search suffixes for Ovid, and Ovid is so it uses Medline, which is also PubMed, but it's Ovid is the researcher's PubMed. And so these particular suffixes may be how they were able to not limit by language of publication. But the thing is, the more I read about this, the more I got confused. And so I really can't say much, and I can't be as critical as I like to be with the methods, just because it was a few hours of my time. And I decided to move on.
I just imagine a patient coming into the room and hey, Erin, we have a session. Not right now. I'm researching this.
Do you have any idea what .tw means? So that was my week.
And now a quick break to tell you about our sponsor. This episode of the Senior Rehab Podcast is sponsored by Health IQ. I mentioned before that Health IQ is a special rate life insurance company for health-conscious people like you and me. They have a unique mortality model on health-conscious people that allows them to secure lower rates based on actual data. You can think of it like good driver savings on auto insurance. They also have a unique underwriting process where instead of using common measurements like BMI, they use waist-to-hip ratios, cholesterol calculations, and much more to demonstrate a more accurate view of someone's health. So if you're in the market for life insurance to protect your family and have a little bit of peace of mind, I highly encourage you to go to healthiq.com/SRP to get your free quote and help support the show. Thanks.
So after these search methods were implemented, they were left with 2,552 articles. So for study selection, articles were included if they compared larger numbers of medications to smaller numbers. And that's not 15 to 10. It could be 2 to 1 as well. It's just a difference in magnitude. They excluded studies with populations of people living in assisted living facilities, nursing homes, people who are admitted to hospitals, or people who are receiving care in the emergency department. They excluded observational studies such as case series specifically, and they excluded articles that didn't examine a health-related outcome. They also excluded articles that determined the sole measure of polypharmacy as the prescription of inappropriate medications or number of medications without examining the number of medications prescribed. So then what they did to figure out their search strategy was they looked at 50 titles and abstracts, and each of these 50 titles and abstracts were reviewed by the 3 authors to check their process and to make sure it was consistent. And then the rest was done by one person, and they included articles and then re-reviewed to check the appropriateness of inclusion. And then after they hashed out their system, all included articles underwent a full text review. That's 2,500 articles for a full text review.
And you thought that you're not using your time.
You're right. I didn't read 2,000 articles this week. All right. So then for data extraction, they took out information about the study design, the study population, the measure of polypharmacy, and the main findings. And of course, disagreements were resolved through discussion. I really don't like that.
I know that you don't like it.
It makes me angry.
I know. It's fine. You deal with your anger. You deal pretty well with your anger.
I just wonder what they discussed. That's all.
Things that they didn't agree on.
Cool. Thanks, Tolly. All right. So they found that the quality assessment was really difficult because most of the articles were observational. Keep in mind they were trying to leave out more observational studies, but they ended up just excluding case series specifically and keeping other ones in. So what they did, which I thought was really clever, was that they focused on confounding, specifically the adjustments that the studies made for chronic illnesses. So for example, medication adherence could be considered one of those health outcomes that they're interested in. And so, someone with dementia is unlikely going to be scoring better than someone with diabetes because there's a cognitive impairment that's inherent to their chronic condition.
Because they do not remember to take their drugs.
Exactly.
Or they get paranoid about their drugs.
Right. And that's not because the person with dementia has more medications on their prescription sheet. So then they classified these particular studies as having levels of confounding adjustments. They were considered to be good if the study used specific assessments of comorbid conditions, including ones like the Comorbidity Index, which I can include a link of probably in the show notes. They were considered fair if they included characteristics associated with health, such as age, which seems a little ageist, but, let them do their thing.
It is, but...
it's a tough one.
It is related to health, unfortunately. I wish it wasn't.
But that makes me think about the 1,000 Norms Project, where they're trying to define what healthy aging looks like because we don't know how.
Okay, but you do agree. It's the same with kids. Kids are more prone to some diseases.
Okay. I think I see what you're saying. So other characteristics associated with health are self-reported health and or function. So those were considered to be fair. And then studies that were poor quality had no adjustments, or if the methods section did not explicitly describe adjustment, which I think was great.
Yeah.
So that's good. They have specific assessments of comorbid conditions. Fair, they just kind of talked about it. And then poor, they didn't.
No
they're just it's fine. Everyone's the same. So then their results got them to 58 articles. They were all observational. They were cross-sectional, longitudinal cohort, or case control. So they just took out the case series.
Did they say why they took off some that were not case series or no?
It would be in the exclusion criteria.
Okay.
They actually didn't say why case series were poo. Then those 58 articles. They found that 23 of the articles examined polypharmacy with falls or fall-related outcomes, which they called dizziness, fear of falling, and a couple other things. 14 of those 23 were considered to be good quality, and 12 of those 14 had a positive association between polypharmacy and falls. And this means that the polypharmacy was considered to be taking 4 or more medications or 1 risk medication. Which we'll talk about in a little bit because that comes up later.
Okay.
Yeah. Because
I was going to ask and then you said things.
Of the 23, we have 14, and then we have 9, which were fair or poor. 7 of these 9 had more than 1 positive association between polypharmacy and fall-related outcomes. So they both, on the whole, demonstrated that polypharmacy and falls may be related or associated. Next were the adverse drug events. So they found 14 articles that looked at adverse drug events. 8 of these 14 articles were considered to be good quality, and 5 of those good quality articles found an association between polypharmacy and adverse drug events. And one of these articles had patients that were taking 14 or more medications, which made me sad. That was one of the good quality ones. 6 of those 14 about adverse drug events were considered fair or poor quality, and 4 of those 6 demonstrated associations between polypharmacy and adverse drug events. Okay, then there are 2 more. They found 10 articles that looked at polypharmacy and hospitalization and mortality. 4 of those 10 articles were classified as good. 3 of them found an association between the number of prescriptions and hospitalization or mortality, and 1 found an association between flu-related hospitalization and mortality and polypharmacy.
Did they say which were more prevalent? Which adverse drug effects were?
Not in this review, but they do have all their citations, so it could be something that, traversing through the literature, we could learn about.
Okay.
Yeah, that's a good question, though.
So we were talking about hospitalization?
Yes, we were at hospitalization and mortality with regards to polypharmacy. So 4 were considered good quality. We talked about that. 6 were considered fair or poor quality. And 3 of those 6 demonstrated an association between the number of prescriptions and hospitalization or mortality. Out of those 58 articles, the last 15 were just about general markers of health, function, cognition, risk of developing new disease, and Parkinson's disease specifically, which, okay.
About the hospitalization, was it the length or the amount of times they're in and out of the hospital?
Just hospitalization, like going to the hospital. The 15 articles that they found about all those things, out of 11 of them were good quality, and all 11, demonstrated an association between the number of prescriptions and the outcome of interest, be that health, function, cognition, etc. 4 were considered fair or poor, and all of them found an association between the number of prescriptions and the outcome of interest. So those are the results. All right, on to the discussion. So I wrote, nebulous definitions strike again. The quality of the information that we have is poorer because we don't have a defined definition of polypharmacy. However, I personally just can't berate the powers that be for not making a definition without offering a solution, which I can't do because the information that we have in the research isn't where it needs to be. So it's like this chicken versus egg sort of issue.
No, it looks like you lose sleep over it. Don't.
I like things to have definitions.
Everybody does, but that's part of life to realize that things don't have definition and kind of play with what you have.
But then I try to think of like, okay, well, if it needs a definition, how could I help it have a definition?
I personally like, out of the 2 definitions, I personally like and think that the first one is more accurate.
The number?
The one about a lot of drugs being used more than misuse of drugs.
Okay. I'm still not sure how I feel.
Okay.
So then another chicken versus egg problem. Are these people in poorer health because they take so many medications? Or is it that they take so many medications because they're in poorer health? Or is it like a spiraling effect where there's more medications in poor health and more medications in poor health? So there's that to consider when you're talking about things like polypharmacy. So then the author's expectations for the results were that the studies that didn't adjust for the confounding of chronic conditions would be more likely to demonstrate that polypharmacy is associated with adverse health outcomes because people with chronic conditions are, on the whole, in poorer health. However, it was pretty much across the board, the good quality versus the fair or poor quality. They all demonstrated that polypharmacy is associated with these outcomes. They also note that there are lots and lots of outcomes, and there are all sorts of multifactorial effects with all of this polypharmacy stuff. So their hypothesis was that polypharmacy is a risk factor for adverse outcomes, and the results of this review say maybe, maybe not, because more research is needed. So they state that the number of medications a person is taking may not be the best indicator of polypharmacy. The authors go on to say that the number of medications could be used as more of a marker for the use of particular medications with well-established risks of adverse events. So like instead of saying the number of medications is the problem, say that, okay, this person is taking a lot of medications. I need to look a little closer into what they're taking for high-risk medications. It could also be a marker for receiving inappropriate meds or as a marker for under-prescribing. So they cite a study where 40% of older veterans taking more than 5 medications were taking 1 or more inappropriate medications and not taking a potentially beneficial medication. So, yeah, but okay, so my criticism with that is that they don't really define inappropriate or potentially beneficial, but that's another one where like we would need to go back to the source material to really see what they're talking about. So there's really a big lack of data defining appropriate medications for older adults with multiple chronic conditions. So, like I said, of course, more research is needed.
Always. It's like, have you ever seen the SNL sketch of More Cowbell?
Not in a very long time.
Oh, but like it's like more research.
Okay, so the authors suggest randomized controlled trials using clinical pharmacists to reduce adverse drug events. They do say that some studies looking at medication reduction have some good preliminary results in reducing falls in older adults and self-reported improvement in their general health. However, these don't address the suggested disentanglement of high-risk meds versus number of meds, which studies in the future should look into. So then they have a table of outcomes associated with polypharmacy, which was really cool. So then this table of outcomes is organized by outcome, and they include study design, length of follow-up, sample size, population, measure of polypharmacy, and the main findings. It's a really cool table, honestly. And then there's this weird conflicts of interest table.
It's like some of it says about the employment or affiliation, the grants and funds, the like.
Yeah. But like it's all no.
Yeah. So like they went because think about it. There's a lot of conflict and interest that could happen when you research something like drugs.
Yeah, but then why don't they just say no conflicts of interest were reported?
Because they want you to know, listen, we went through all of the things that could be a conflict of interest, and those are a no.
Okay.
I actually really appreciate that.
No, what you're saying makes sense. It's just like it's also an ugly table, but that's
it is an ugly table.
It's like Times
fine,
New Roman.
But
I'm also very critical of tables.
It's not that ugly, actually.
I've seen worse.
on the Tinder of tables, I would totally swipe right.
Can you imagine a Tinder of tables? That would be a desolate website.
I can barely imagine a regular Tinder. I think it should go on now.
So, Celeste, you ask a great question. Do they define high-risk meds? They don't in this systematic review. And actually, after reading this article, I was trying to figure out if there was like a succinct list of all sorts of medications that are considered to be high risk. And I found like very long PDFs, very dense websites. I found an article of potential drugs in question. It's from 2013. It's called Drug-Related Falls in Older Patients, Implicated Drugs, Consequences, and Possible Prevention Strategies.
Yeah, that should be published.
So, Celeste, I'm really glad you asked that. This list of drugs, which is probably, I think like in general, it's like psychotropic medications, ones that mess with hemodynamics.
Yeah, all the blood pressure.
Anything that promotes dizziness.
Like aspirin, like blood thinners.
Yeah. So all of them. The point of this article / my thoughts are that polypharmacy may not be the big bad wolf that we seem to think it is, but it may be an indicator that we should take a closer look at the specific medications, like ones that increase the risk of falls, and counsel our patients appropriately. So that's what I have for this article. Tali, do you have anything you want to add? Anything you want to comment on the beers list? What's the beers list?
There's a list of beers? What is the beers list?
It's a list of potentially harmful medications for older adults.
It's actually a little more exciting than an actual beers list.
Why not both? I'm sorry. That's awesome. So that's like exactly what I was looking for. So thank you very much, Celeste. I love it.
Good job, Celeste.
Yeah. Thank you all for listening, and thanks for tuning into this Senior Rehab podcast. I'm Erin Carey.
And I'm Tali Spaceman.
And as always, stay funky.
Hit me! Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.